So in this unit, we are going to learn about community diagnosis. We will see what is community diagnosis, how community diagnosis will be different from individual diagnosis. Then what is the purpose of doing a community diagnosis, importance of community diagnosis, characteristics of community diagnosis. Mr. Harris, if you can mute yourself, please. Okay, thank you. What is a community analysis and how it is going to help us? What are the types of community diagnosis? And then the steps in implementation of community diagnosis. What is epidemiological transition? What is right of health? And what is ecology of health? So have patience. Today class will be more elaborate, a long class. I will try to finish it in 60 70 minutes. Hope we are going to do that. Okay. So, uh, what is community? So, when a cluster of people or a group of people reside together with some characteristic, this characteristic can be in terms of geographical location, the ethnicity is something which is the race or tribe they belong from, the housing condition or occupation. So if they are having any one of these characteristic or similar characteristic, then that cluster of people, the group of people, will be known as community. So they are having a common characteristic or an interest of living together within a larger society. So this is what community is. Now, what is community diagnosis? So community diagnosis is nothing. It is a assessment of health status of a community in relation to its social, physical, and biological environment. So we are going to assess health status of a given community, and right. So how we are going to assess that health status? Health will be in terms of blood pressure, pulse rate, or temperature. So that is the health data, but this will be analyzed in relation to the social status, the physical status, or the biological environment, like the age of the people, the society, the strata. Are they from BPL, APL? No. So in relation to those factors, social factors, physical factors, whether they were living a sedentary lifestyle or whether these people were doing some rigorous physical activities. So this is known as community diagnosis. So community diagnosis is nothing. It is a process in which there is application of techniques of diagnosis of an individual to the community. So first we will do diagnosis of the individual, and then that individual is a part of the community. So community identification is nothing. Community diagnosis is nothing but identification and quantification of health problems. So first we are going to identify what is the health problem which a community or a group of people is having, and then we will try to quantify in terms of number. So how this is going to affect, and when we are talking about quantifying in terms of quantifying in terms of number, so that will be in terms of morbidity and mortality. We have discussed in detail about mortality and morbidity. Mortality is something related to death. Morbidity is something which is affecting your lifestyle, which is causing some certain amount of limitation to your daily activities. So that is mortality. So this quantification will be in terms of mortality and morbidity rates and ratios, and identification of their correlates for the purpose of identifying those at risk. So first we will identify what health problem a community is having, and then we will quantify what will be the mortality or morbidity rates because of that identified health problem. And then ultimately we are going to identify the risk factors, or the persons in the community which are at more risk, like uh, certain diseases are affecting some gender, like, and certain diseases are affecting more elderly people. Certain diseases children are more prone to. So those identification, quantification, and then defining upon correlation, like which strata of the population is more prone or more risk at risk because of those diseases. So as I said, we will be learning about individual diagnosis and community diagnosis. So in individual diagnosis, most of the time patient is aware of the problem, whereas community diagnosis, people may be aware or may not be aware that there is something called fluorosis. So that is because of excessive fluoride in the water. Certain times community is not aware that they are consuming more amount of fluoride, which is hazardous to their health. So this is something which is not known to the people, whereas some of the patients who are having no dental problem or bone malformation, they are aware that they are having some problem and then take care of that. But whereas at population at large, they might not be aware. So in community diagnosis, patient take initiative for solving their problem. Whereas in community diagnosis, community rarely takes any initiative because they think that this is not none of my problem, because everyone is getting affected, so they have to take care of themselves. So there comes no in picture the role of government. If a community is getting affected in a larger side, so there that government has to intervene. So for individual diagnosis, pathological conditions affects patient alone, whereas in community diagnosis, these cannot be treated or isolated. If we are trying to treat community at large, we cannot treat them as isolated cases or isolated occurrences. So we have to do something at a mass level, to take care of that community health problem. We have to identify, we have to do community diagnosis, identify what the root cause is, who are at the risk factor, more risk to get that disease, among whom they are having more of mortality, more of morbidity, how we are going to take preventive aspect, preventive measures to take care of that community problem. So individual diagnosis, it may or may not be related to environmental factors. Whereas in community diagnosis, if we will analyze and we'll see that each condition is linked to the interrelated factors in the environment. So as I said, community diagnosis, I gave example of fluorosis. So fluorosis can be because of the water supply in that area is no having more of fluoride. Water is coming, that fluoride density is more in that area, because of which the water supply, that the bore wells or the well which is used for water consumption in the area is having that fluoride. So these issues are related to community factors. So why we are going to do community diagnosis? What is the purpose? So the first purpose we have already identified in the definition. It is identification and quantification of health related problem. So until or unless we do not know the magnitude of the problem, we are not going to come up with any health measures or public health measures as per se. So and then community diagnosis will help you in identification who, which part of population, or which age group of population, or which gender of the population is having more risk to be affected by those disease. Identification of community needs and their problem. As I said, again I'm giving example of fluorosis. So we have to identify that we need to come up with a health measure where this fluoride, excessive fluoride in the water has to be taken care. So we have then on basis of this diagnosis, we have quantified, we have identified, and then we are going to determine how we are going to use the available resources. Whether we are going to supply water from outside, or we are going to put a filter over there which will be filtering excessive fluoride of the water, available water resources over there. So this will help us in prioritizing and planning. So when we am saying prioritizing, so we have to prioritize, like we have to see how the children's dental problem has to be taken care, how if there are bony malformation happening in the community, how we are going to take preventive aspects of that. And then accordingly we have to allocate resources and set our priorities and plan accordingly whom we have to target, whom to we have to give health education, on whom we have to give preventive aspect, whom we have to take care of curative aspect. So all these we have to do, and this is the purpose of doing community diagnosis. So what is that? What is the importance of community diagnosis? Now, when we do community diagnosis, this gives a baseline information. Like if I am doing a community diagnosis or for a community today, it will give us the baseline parameters. Baseline parameters like what was the average blood pressure of this community today? How much they were having pulse rate. So this will give an idea that what are the set health parameters of a identified community. Then based upon that, it will help us that if we are going to take any health decisions, then this should be based upon the information and the evidences which we have gathered from that baseline uh, data. And then accordingly we can set our priorities. Like I had been to tea gardens in Assam. Now during my visit I realized that tea garden laborers are consuming excessive of salt. They are taking salty tea. Now because of salty tea they are having increased blood pressure. Now, this is something which we came to know during this community diagnosis or when we are doing assessing health of those tea garden people. So this was not known to me that people consume salty tea over there. So this was something which we realized, and during that camp we realized that people were not aware that they are suffering from increased blood pressure. So accordingly we had to set our priorities. We have to start orienting them that don't consume much of salt which is hazardous to your health. So accordingly they were sensitized on doing at least 30 minutes walk, or to take, if they have to undergo regular health checkup, so that they can take care of their blood pressure, and accordingly they were administered medicines. So this helps in the health authorities to assess outcome and results in longer term. So if the health authorities or or a PHC or CHC, they keep on doing that diagnosis, community diagnosis in their area regularly, they will have a very much clear knowledge of hotspots of certain diseases, like where they are going to get more of dengue cases in summer, where they are going to get more of UTI cases. So if this community diagnosis will help them in creating or awareness about the hotspots in their community. And then this community diagnosis will help to get community member and stakeholders and a wide variety of partners. So when you are doing community diagnosis, it is important to involve community or or a local NGO or government employees staff, like for doing you do mass administration campaign for deworming. So during that they involve school teachers. So this is a example of community involvement where you uh, involve multiple partners, multiple stakeholders. So community diagnosis is involved in decision making process, and this helps in understanding the difficult choices that need to be made and build support in addressing health needs of a community on a wider basis. So what are the characteristics of a community diagnosis? So this community diagnosis should be able to address important community problems, and it should be able to identify most of the targeted health events, and it should be adequate in reflecting changes in distribution of events over time, person and place. So what is what what is important, that your community diagnosis should not only identify health problem, quantify the health problem, and help setting in prioritizing your implementation plan. This should also help you in reflecting changes. Like suppose you identified a problem today, so down that line, if you are going to see whether your community diagnosis has impacted or has changed community profile over a period of time, so your community diagnosis should answer that problem also. So like suppose if you have identified that a cluster is having more of a fluorosis problem, so once you identified that problem, you took some decision and you went over there after 3 months. So definitely your community diagnosis results should tell you that the cases of dental fluorosis or bony malformation has reduced in the community just because of your that community diagnosis. So it should be participatory, where community or different stakeholders should involve. It should be uncomplicated, sensitive, and in a timely manner, because if the interventions are not going to give result over a period of time, then this should not be effective. And moreover, last but not least, it should be inexpensive. So because you are rolling out program at a community level, so your interventions should not be costly. So it is not going to cost much of the cost. So it should be more in terms of screening, and then more of a community awareness, how and what to do so that they are not going to get affected by those health problems. So how this community diagnosis has to be done? So this has to be done using a tool called health indicators. So if you remember, last time we have discussed about multiple health indicators. So we have to do a community diagnosis using a tool called health indicator, which are variables used for assessment of community health. And indicators must be valid, reliable, sensitive, specific, feasible, and relevant. So for doing community diagnosis, we should do community analysis. So what is community analysis? This is the process of examining data of definite needs. So when you, as I said, when you are doing community diagnosis, you will be collecting various data. So you have to analyze that data, and that analysis is known as community analysis. So to analyze assessment data is helpful to categorize data. So the data can be categorized under demographic data, environmental data, socioeconomic data, health resources and services data, health policies data, and study of the target groups. Now, what are the target types of community diagnosis? So there are two types of community diagnosis: comprehensive community diagnosis, which is aimed to obtain general information about the community, and second is problem oriented community diagnosis. So this is basically when people are already aware that there is a problem in the community that reaches to health facility through press, media, or someone goes and inform, or you get a repeated type of cases from a same community, same locality. Then you are aware that there is a problem in that community, and then you respond to that particular need. So there are two different types of community diagnosis: comprehensive community diagnosis, and then problem oriented community diagnosis. So what are the steps in implementation phase of community diagnosis? So you have to determine an objective, what you are going to do. Then you have to define your study population. Who will be your study population? It will be within a radius of this many kilometers, or the household having a geriatric population or a pediatric population. It depends upon the type of cases and the type of community diagnosis you are doing. So determine, you have to determine which type of data you are going to collect, whether it will be just health data or health data with social data, or environmental data, or some other data you are going to do. So data collection has to be done, and then you have to review those records. This data collection can be in terms of record review. So record review, when I'm saying, so you will be doing a record of the patients which have visited in your clinic in past 1 month from a given area, or that data collection should be in terms of surveys done or the observations done, or it can be in terms of interview taken, or it can be a participant observation, like certain member of your PHC goes to a area and then they observe over there the behavior, the problem, and then that can be also one of the way to collect data. So for collecting data, you have to develop a questionnaire, and this should be a structured. So it can be survey questionnaire or interview guides or observation checklist. If you are going to observe, what all things you are going to observe. So this is just to ensure that the data collection should be in a structured format, or and whoever so goes, mixture A, B, C, or Miss A, B, C, whoever goes in the field, they collect same sort of data, and there should be a SOP for that data collection. So that data collection will be standardized. So once the data is collected, the data has to be gathered, data collection, and then accordingly that data has to be summarized and presented in form of infographics. Data analysis has to be done, and then once that data is analyzed, you will come to know what are the problems which has been identified in terms of number, as I said, magnitude. Is there a seasonal trend, or diurnal variation, like this is more identified, people are having more sort of complaint in the daytime or night time or evening time, and it should be compared accordingly. So these are the steps in the implementation phase of community diagnosis. Now, health indicator classification. This is a repetitive classification of health indicators. We have already discussed this in our last class. Again, I will quickly run through these slides. So as I said, indicators are mortality indicators, morbidity indicators, disability rates, nutritional status indicator, healthcare delivery indicator, utilization rates, indicators of social and mental health, environmental indicators, socioeconomic indicators, health policy indicators, indicators of quality of life, and then other indicators which are not clubbed in any of these indicators. So when you are doing community diagnosis, you have to look into which type of indicators you are going to not tap for, look for. So accordingly, you can plan. So mortality indicators. So mortality, what is mortality indicator? Mortality indicator is the traditional measure of health status, widely used because of their readily availability. So how we are going to know about mortality rate? This is through the death certificate. As I said, mortality is related to death. Mortality rate means death rate. So because everyone which dies in a country, they has to be issued a death certificate, and whoever borns is being given a birth certificate. So through death certificate, you will come to know death rates. So these can be crude death rate, specific death rate, age wise, disease wise. So this will help you in calculation of expectation of life, infant mortality, under 5 mortality. There are multiple types of mortality. So when if you are going to look, no, TB mortality, cases died because of TB. So if some death certificate has been issued by a hospital and there the cause of death is mentioned as TB, it is attributed to TB mortality. If it is mentioned, diarrhea, then that can be attributed to diarrhea mortality. So it depends. So if a person dies within, if a neonate dies within 28, this will attribute to neonatal mortality. If the child dies within a first year of life, then this will be infant mortality. If the child dies within first 5 years of life, this will attribute to under 5 mortality. So these are different. Now, if a woman dies during pregnancy or while delivering a baby, so that will attribute to maternal mortality. So accordingly, the case fatality rate, proportionate mortality rate, there are multiple mortality rates. Now, morbidity rates. So what are morbidity rates? So data on morbidity are preferable, although often difficult to obtain. So previously we have talked about two things: incidences and prevalence. So if I say that what is prevalence of HIV today, so the number of HIV cases which has been identified today will attribute to incidences. Now, when I will say what is prevalence of HIV as on today, so this will be HIV cases which has been detected previously, I mean day before today and today also. So whatever cases has been identified today, so both cases will be a part of prevalence. So incidence, what is happening today, and prevalence is like previous plus today. So this is something which you should know about. Admission, discharge, morbidity. So there is something called disability rate. So number of days when that person is having any, if any person who has been identified or injured or broken hip, fracture, so they can have restricted activity. So number of days that person is having restricted activity, this will be attributed to disability rate. It can be bed disability rates, work school lost days because of a specific problem for a specific period, expectation of life free of okay. Now nutritional indicators. Now uh, okay, nutritional indicators can be calculated through anthropometric measurement. And so when I'm saying anthropometric measurement, this will be weight, height, these are anthropometric measurement. And then when nutritional indicators in cases of anemia is also one of the nutritional indicators. Now prevalence of low birth baby, those children who are born less than 2.5 kg birth weight, they are low birth weight babies. So we have to see how many cases in a month are there where the birth weight of a child on a neonate is less than 2.5 kg. So then, as I said, anemia cases, hypothyroidism cases, night blindness cases, these are uh, proxy indicators or indicators of nutritional indicators. Similarly, healthcare delivery indicators, doctor population ratio, doctor nurse ratio, population per bed ratio, population per health center. So these are all. Now again, utilization rate will be in terms of proportion of infants who are fully immunized in first year of life. So government is having certain health programs. Now this is targeted to achieve 100% coverage. Now, but most of the time we don't achieve that 100%. So if a area is getting showing that their immunization coverage is 85%, so this is a utilization indicator that universal immunization program of government of India is having a utilization ratio of 85%. So this is something, proportion of pregnant women who receive ANC. So government of India aspires that every pregnant woman should undergo ANC checkup, whereas most of the time it is either 80%, 75%. Some of the states they are having 90%, 92%, and some of the states they are having even 60%. So again, hospital bed occupancy rate. This is again an indicator where how many beds of the hospitals are being utilized for the patient. So these are the proxy indicators for utilization indicator. Now social mental health indicators. You can go through all these things. I have already discussed about this. Suicide, homicide, road traffic accident, alcohol and drug abuse cases. These are proxy indicators for that. Social and mental related problem. Population pollution indicators are proxy indicators for environmental indicators. Access to safe water and sanitation. These are WAS indicators which are used for environmental indicators. Now, socio-economic indicator, again in this you will see GDP, gross domestic production, gross national production, GNP, levels of unemployment, literacy rate, family size, housing condition. These are basically used during census. They used to see number of rooms per person room, whether they are having AC, we are having fridge, whether they are having cycle, vehicle, all these data it is being captured. So again, health policy indicator when you are seeing again the GNP is being taken care, proportion of GNP is spent on health related activities. So you always see during budget what will be what is the allocation for health, what is the allocation for education. So these are basically targeted towards improving your health indicators and improving your educational indicators. So these are when we are talking in terms of health, these are health policy indicators. So proportion of total health resources devoted to primary health care. So these are and then when I'm talking about other indicators, they are indicators for quality of life, basic need indicators, health indicators. Now there is something called quali and daily. So quality added life years because of any intervention. If the quality years is added to your life, that is quali, and then daily is disability added life years. So if a person is having some sort of injury or some disease because of which a disability is added to his life, so this is something called quali and daily, which you should be aware about. Now there is something called epidemiological transition. So whatever I have discussed, you guys are clear to that, or you are having any question? Hello.
So, sir, one question, sir.
Yeah, please.
Hello,
Yeah, please
sir. Is it
go ahead.
audible, sir?
Yeah, I'm audible.
Sir,
It's audible. Uh,
may sir, my question, first question is how I should calculate the morbidity of a community.
Mortality.
Mortality, I can calculate from the reported deaths.
Okay.
And
See,
I'm thinking
morbid.
about how to calculate the morbidity.
Okay, morbidity is never attributed
Yes,
to
sir.
death. Morbidity is never attributed to death. Okay. What is attributed to death is mortality. Is that clear?
It is clear. So I just want to know how to calculate the morbidity of a certain community.
You, you want to calculate mortality or morbidity?
Morbidity, sir. Morbidity.
Okay, so again, I'm just clarifying morbidity. How we are going to define morbidity? Morbidity is the condition of suffering from a disease or a medical condition. So when you are going to calculate morbidity, so you have to identify that because of which disease you are going to calculate morbidity. Okay, so that morbidity can be because of TB. So number of cases which has been identified in a community, you have to first take care of that, and then how that community is getting affected through that TB, whether that is taking them to bedridden cases or that is affecting their quality of life. So then you can calculate the morbidity rates. Like suppose 100 people were identified from a community, and out of 100 people, 10 were bedridden. Got it? So those 10 people are no people affected were 100 from that disease, whereas 10 people were there who were bedridden for a longer period of time. So that in that case, the morbidity rate because of TB in a given community can be 10%. Is that okay to you?
Okay. 10,
So
yes, 10 by 100.
okay. Uh, any other questions?
Another question is this bed occupancy rate I can calculate and understand, but what about bed turnover rate?
See, these are basically don't go into these intricacies, I will say, because bed turnover rate and you are talking about bed turnover rate, right?
Yes, sir.
Okay. So basically, these are more important for hospital administration guys. Okay. Those who are involved in public health, they should not be more bothered about that. But again, how to calculate hospital bed turnover rate? It is calculated in terms of number of discharge. Okay. Or this, when I'm saying number of discharge, it includes number of deaths also during those admission. Okay. So number of discharge included the number of
Okay.
deaths in a given period of time, divided by number of bed in that hospital. You got? I will give
Okay,
you
sir.
I will give you an example. Like suppose a hospital is having 100. It's a 100 bedded hospital. Okay. So
Yes, sir.
suppose if you are calculating bed turnover rate for a month which is having 30 days. So uh, total number of beds during that period will be 30 into 100.
100. Yes.
Okay. So
Yes.
that will be your denominator, and numerator will be how many people got discharged from that hospital, and if there were any deaths. So you add those. So suppose in altogether it was 20,000. No, 20,000 people were discharged, and out of 20,000, 10 were deaths in that. So altogether it was 20,000 divided by 30 into 1000. So this is a hypothetical number I am trying to give. Okay. So number of discharge including death divided by total number of beds in that given period of time. I hope I am clear.
Thank you, sir. I am clear now.
Okay. Okay. So now next few slides we will be discussing about epidemiological transition. So what is epidemiological transition? And then we will be talking about right to health, which is one of the fundamental right given to citizen of India. Okay. So the general shift from acute infectious disease and deficiency disease characteristics of underdevelopment to chronic non-communicable disease characteristics of modernization and advanced living levels of development is usually referred as epidemiological transition. uh, you understood the statement, or you want me to make it more comprehensive? So initially, we had a population which had been suffering from more of infectious disease like TB, smallpox, chicken pox. These were the infectious disease we had been suffering before earlier, which was because of uh, certain deficiencies in terms of mineral, deficiencies in terms of health services. Okay. And these were signs of underdevelopment. We were not developed. Now, previously people were seeing these type of diseases, infectious disease. At present, people are having more of non-communicable diseases. If you will see sitting in a uh, hospital setup, you will see more of the patients coming with non-communicable disease, which are like more of diabetic problem, more of a blood pressure problem, cardiac problem. So these are lifestyle diseases. These are basically not any sort of disease in as we had been seeing in infectious diseases. So these non-communicable diseases are because of modernization. Before, previously we were living. India was a rural country. Now we have developed ourselves and we are a modernized urban country. So we have very rampantly urbanized ourselves. So all these diseases has shifted towards communicable to non-communicable, and these are more of a lifestyle diseases. So again, modernization is showing a development. So transition from rural to urban, underdeveloped to more modernization. So this is reflecting in terms of epidemiological transition. When we are talking epidemiological transition, it is in terms of the cases which we had been seeing in our clinic. So this epidemiological transition is showing us cases of non-communicable diseases which was previously communicable diseases. I hope this is very clear to you guys now. Okay. So the disease epidemiological transition describes changing patterns of population distributions in relation to changing patterns of mortality, fertility, life expectancy, and leading causes of death. So there are two major components of epidemiological transition. So first component is changes in population growth trajectory and composition, especially in terms of age distribution from younger to older, and changes in patterns of mortality, including increasing life expectancy and reordering of the relative importance of different causes of health. So first is this epidemiological transition is because of the population growth over the time. So previously we were having a life expectancy of 40 years, 45 years. Now we can see life expectancy of approximately 70 years. So as the life expectancy increases, the cases changes. The types of clinical cases, clinical problems we get changes accordingly. So for epidemiological transmission, Omran's theory is very important. So there are four or five propositions in that. Let me see, five propositions. So there are five propositions of this theory. So first proposition says that the theory of epidemiological transition begins with major premises that mortality is a fundamental factor in population dynamics. So this proposition says that mortality is there and mortality is going to affect your population dynamics. Second proposition says that during epidemiological transition, a long-term shift occurs in mortality and disease pattern. Uh, why this shift is there? Because as I said, life expectancy changes, and thereby pandemics of infections are gradually displaced by degenerative and man-made diseases as the chief form of morbidity. So these degenerative diseases, what are those degenerative diseases? These are geriatric problem. And then man-made diseases are like, as I said, these are lifestyle diseases because we are not involved in much of physical activity. So first transition phase called age of pestilence and famine, characterized by high and fluctuating mortality rate, variable life expectancy with low average lifespan and periods of population growth. As I said, during this transition phase, life expectancy was very less. The second transition phase is characterized by age of receding pandemics and marked by declining mortality rate and increase in life expectancy from 30 to about 50 years of age and more sustained population growth. So during that, initially there were more of pandemic swine flu, and then if you will see the industrial revolution time, there had been multiple infectious disease which has affected population at large. So over the period that pandemics has reduced and life expectancy has increase. The third transition phase, age of degenerative and man-made diseases. So degenerative changes, as I said, these are debilitating and geriatric problem, and man-made diseases are because of lifestyle changes. The third proposition, during that epidemiological transition, the most profound change which we have seen in health and disease patterns are during among children and women. So you will see most of the health conditions where children and women are more affected. Now, fourth proposition is the shift in health and disease patterns that is characterized by epidemiological transmissions, which are closely associated with demographic and socio-economic changes. So this transition shows that certain diseases are affecting people which are living at like suppose hilly terrain. So there you can see more of a natural calamities, flash flood happening nowadays. Now, certain diseases like malaria, which are still prevalent in low socioeconomic conditions, where we have not ensured very good environmental condition, and this shows that we are um, modernizing at a rampant rate. So fifth proposition is peculiar variation in the pattern, the place, determinants, and consequences of population changes. Like there are three models of this fifth phase. So the classical modern or the Western modern, which is example of European countries. The accelerated model where things has changed very fastly is Japan model, and the contemporary model. So like this is again no, we are third world country. Why we are being called third world country? Because we are still developing. So if you will see European countries, they are already developed. Japan has already accelerated or no achieved that developed status from developing country, whereas we are still in developing countries. So you can see a wide variation in these epidemiological transition in these three countries. European countries are having more of a different public health aspects, whereas countries like Japan, which has already developed, they are seeing a different transition phase, whereas countries like India and Africa, we still have those classical representation of infectious disease as well as non-communicable disease. So as I said, overweight, obesity, these are the cases in childhood. These are the cases which are more seen in developed countries like European countries, whereas countries like India, we are still having cases of undernutrition, which is a classical representation of underdeveloped country or third world country, because we are moving towards developed country, and whereas we are still underdeveloped, so we are seeing cases of obesity also. We are seeing cases of a stunted and underweight cases also. So when I said European countries which are already developed, they are seeing cases of more cases of road traffic accident, more cases of STI, and these are equally prevalent in our countries also. We are, because we are moving towards the modernization area, we are rampantly urbanizing ourselves. So, what are the mechanisms involved in epidemiological transition? So, these are demographic changes. As population becomes healthier, the mortality rate is reduced, and then life expectancy is increased, and diseases which are more frequently affecting elderly population, such as cancer and disease condition. This was all about epidemiological transition. Now, what is right to health? The right to health is a fundamental right which is given by Constitution of India, and this is given so as to ensure quality healthcare services and transparent healthcare services, wherein more health staffs are involved. Spaces are given to the patient, and they uh, these all are there to reduce out of pocket expenditure. The right to freedom of healthcare uh, is something which is because every individual is having a right to be healthy, is a kind of freedom, and it's a freedom from disease. So this is a right which has been given to every individual by our constitution. Why we need right to health? We need right to health because to have a transparent and quality healthcare services in the country, eradicate dubious healthcare services. When I'm saying dubious healthcare services, these are to cut out those thais who had been delivering births deliveries were being done by thais. If you will see 20 years 30 years back, there were still uh, so-called health practitioners who were not having any certificate, and they were not at all accountable. And then this right to healthcare has been over there to address health crises and to increase the standard of living, to list out problems associated with medical terrorism. Now again, when I'm saying medical terrorism, this is in terms of nexus between pharma and healthcare services, nexus between diagnostics and healthcare services. So irrational use of medicine, irrational prescribing diagnostic services, even if it is not required. People are being advised to undergo MRI scan, CT scan. So this is what medical terrorism mean. And then to transform India into a welfare state in real sense, and to harness an affordable and uniform medical treatment for all, where people should not be treated on the the layer of society which they are coming from. They should be treated irrespective of whichever caste, creed, and society they come from. Now, who is responsible for health? Is it the individual himself, or is it community, or is it the state? When I'm saying a state, I mean country, or is it a international issue? The international community has to take care of health. Now, the onus lies with each four of them. So, what is individual responsibility? So, self care is individual responsibility. If you will not take care of yourself, no one is going to ensure your health. So, when self care is over there, you have to take proper diet, proper sleep, proper exercise, now periodic checkups, ensure that you are taking vaccination. Even if government has given free universal immunization program, no one there are still no, population at large who are not taking ensuring those vaccination to their children because of certain some or the other stigma or misinformation which is rampant in the community. So e- government has ensured a good hospital, good health education delivery mechanism. ANM is there, ASA is there, but still, if we are not going to eat food on time, if we are not going to take 8 hours of sleep, if you are not going to do physical activity, you cannot ensure your health. So, individual responsibility is also there to ensure uh, their health. Now, community responsibility. So active involvement of family and community in health here, health matters. This should be in three ways. So providing manpower, logistic funds, taking part in planning, and utilizing services. So this community comes in when you will see programs like VHND, VHSND, where community plays an important role. So community is a part of VHS SNDs throughout India, and then they ensure that what has to be done, what funds has to be utilized for which activity, and then they themselves plan those activities in their areas, and they ensure utilization. So community mobilization is a part of the community, and then planning is also a part of the community. Third, uh, state responsibility. So Constitution of India says that maintaining health of the people is the responsibility of the state. So this is a very strong statement. But when you will see uh, the working of the state, it's little dubious. Allocation of funds are being irrational certain at times. Certain at times you will see shortage of medicines. I recently I had been talking to people in Delhi, and then I realized that there is shortage of anti-tubercular drugs for almost 6 months. Government is not ensuring. Most of the states they are at a stock out situation. So this is a state responsibility. Now, how comes international responsibility? So there should be cooperation between different countries. Cooperation in terms of experts, drug control of communicable diseases. Like recent example has been COVID-19, where COVID-19 spread from China. If China would have declared or uh, alarmed other countries, they would have closed their international boundaries. So they would have confined COVID-19 very effectively, but somehow that has not done. So again, there is an example of cooperation, good cooperation between different countries, wherein those countries who failed in developing vaccines against COVID-19, they were being provided COVID-19 vaccinations from different developed countries. So that's how we have you know uh, survived these difficult times. So now ecology of health. What is ecology? So relation between man or woman and his environment. So relationship between human and the environment which he is living in. So health is always and seen as an equilibrium between human and his environment. So human ecosystem is made up of two things: natural environment and man-made environment. So if there are changes in the environment, this affects health. So this we have already discussed at large during epidemiological transition and community diagnosis, urbanization, industrialization, deforestation, making up of dams and canals. These has affected our health. So the examples of these rapid urbanization and industrialization has led us to malaria and then Bhopal gas tragedy. Pardon me for the typo error over here. So this is gas tragedy. Okay, and filariasis. These are examples where we have affected our own health, and this has been because of the rapid urbanization, industrialization, deforestation. The current examples can be the recent flash flood which has happened in Uttarakhand and Sikkim. So people had been affected very badly. So these are a few examples. Okay. I think I'm done with the session. If you are having any questions, feel free to ask. Otherwise, this session is done from my end.
Excuse me, sir.
Yeah, please.
Will we be getting any study materials from your end
Yeah,
apart from the
I
apart
will
from the
be.
PPTs?
Okay. So, can you share the syllabus? Because I am having your syllabus, but I cannot see any reference material, like which book to go through. So if I can refer those documents, then accordingly, because the reference material which I have collected, okay, is
Okay.
this is not at all from PARC. So usually, if you study epidemiology chapters are through PARC, but specifically this chapter is not covered under PARC, and if covered under PARC, you have to go through each and every page. Okay, so
Yeah.
if there is any, like, I have referred some of the research articles. Okay,
Okay.
and there is a book of epidemiology by Bonita. Okay, I will share that book with Seema or Noor. They will share it with you. Is that okay?
It's okay, sir. If you're in the WhatsApp group, can you please share it there also so that we can all
Yeah,
refer to it?
I will do that. Give me a couple of days or a week time. I will definitely
Okay.
share it.
Okay. Thank you.
Okay. So if you will go through this slide, that is more than enough to pass. But if you are really interested in learning epidemiology, there are few good books which I will definitely share in the group. And let me tell you, it's almost 15 years I have finished my MPH, but I still go back to those books. And the more number of times I read, I usually used to get a different, perspective of public health. So we are not very fond of reading books now, but the more you will read, the more better understanding you will get. So that's what I believe in, and I would definitely love to share those books. Okay, so I assume you guys are not having any questions. So then we will meet in next class, which will be more about NHM, and I think it will be more of a learning from you guys to me than me teaching you guys, right?
Okay, thank you, sir.
How many years you had been involved in a government system? For 10 years, 5 years, how many years?
Almost 10 years.
More
Almost
than
All
10
of us,
years, sir.
Pardon?
almost all of us are working for almost 10 years.
So it's almost a decade. So you would have seen how you people had been part of NRHM and then it has turned to NHM, right?
Yes.
Yes, sir.
So you had seen, NUHM, NRHM, RCS2. So how things have changed. Probably you can foresee sitting in the system how things have changed. for betterment. There had been a time where there people were very much afraid to utilize these funds. Now people are utilizing these funds. We have seen where PIP has been, planned for an year. Now, since last 2 years, we had seen that PIP is for 2 years. I assume that even your state is people are visiting, NHMED is visiting Delhi for PIP.
NPCC. Yes, sir.
Yeah, yes. So that is supposed to happen by 31st to 4th, if I am right. So all the states representatives are already in Delhi, and that's how the things are working for betterment. Now, if you will see code, budget code also, FMR codes has also streamlined. Previously, there were multiple codes, which has reduced the number of FMR codes has reduced. So people are working for good. We are very much optimistic that in our lifetime we will see a good health system of India. So we'll talk more in detail about the health system, the NHM in next class, and I hope that you guys will be speaking more. I will be learning more from you guys, right? It will be both side discussion.
Thank you, sir. Thank you.
Oh, okay. Thank you, guys.
Thank you, sir.
Thank you.